just to let you know, we're going to record this session. So I'm just going to wait for Cherise to hit that button and then I'll get started.
So I've clicked it now, so we're recording. If anyone doesn't want to be shown on screen, just keep your camera off. And can I just ask as well, if you're in a room with someone and you haven't signed up, or your name hasn't come up, please just put it in the chat so I can know who's attended and we can send certificates out.
Okay, great. So let's get going. So Cherise, you can still see my slides, yep?
Yes.
Fantastic. So let's get started on the talk. There's a little bit of interactivity in this talk. So if you have a separate screen or a window open or on your phone, you can go to menti.com and tap in the code you see at the top of the slide there. And the first question I'd like to hear from people is, how would you rate your awareness, knowledge and confidence on this topic? So thinking about how to support LGBTIQ+ community members when it comes to cancer care or diagnosis. We'll be able to see in real time as people update it. So do grab your phones and there'll be a couple of these throughout the talk. Okay, I'll give it a minute and see if anyone is able to log in and use it. If you're having any problems, of course, let us know in the chat. Great, so we've got one person scoring. A nice sort of middling score. Yep, another one in, thank you. Let's see if there's any more before we move on. But we can generally see that there is a just below average score on the awareness, knowledge and confidence, which is what we expect when we start one of these talks. So we'll revisit this later. So the other thing that I'd like to know from people as well is, where have you received LGBT specific education so far, if any? So if you look down on your phones now, it should have moved to the next slide. If not, there should be a link to let you do it. And just give it a tap and just let me know if you've had similar content delivered before, and if so, where. That's it, and you should be able to hit multiple options. Yeah, great to see. So again, what we expect to see, so a lot of this stuff comes through CPDs or webinars, usually by external providers. Obviously, this is no different, but it's good to really give some awareness to the fact that we're not being taught LGBT inclusive care in our sort of standard curriculum. And this is why things like this are needed, but why we also need change to make it more of a standard provision. So let's get into the meat of the talk. So the first thing we do is we define what LGBTIQ+ means. So if we break it down, LGB refers to sexual orientation, so this is lesbian, gay and bisexual, and this is how we feel sexually about different genders. T in this refers to transgender people, and this comes under the gender umbrella. So gender identity is how someone identifies their own personal sense of gender. We also have I for people who are intersex or have a variation in their sex characteristics, and this is an umbrella term for those who have some variation in their chromosomes or hormone responses or genitalia that outside of what we'd typically assume to be male or female, but it's important to note that when they're born, they're always registered as male or female on records. We also have queer for people who prefer a bit of a broader label so that they don't necessarily have to define everything about themselves without giving that away, but still being part of the community. And we also have the plus for others, which may include asexual and other people. So let's start with sexual orientation and looking into this a bit. So first thing I want you to do is to take a guess at the percentage of the UK population that identify themselves as LGB or other. So basically anything other than straight. Okay, we've got a 7% on there. 3.5 and 7. Okay, so the majority is going for 7%, which is what we normally see on this slide. The data from the GP patient survey shows it's actually about 5%. So let's look into that data a little bit more. Although it is 5%, we can actually see that there is a distribution that shows that younger people are more likely to come out and reveal that they are LGBT or other. So that 7% may actually be where we end up eventually, because although we can see this tailing off of disclosure over the age groups, I would suggest that this isn't, as people are getting older, they're less likely to identify in this way. It's more that we see generations growing up in a society where they're more likely to be able to come out safely. So just because we see this data for young people, it doesn't mean that older LGBT people aren't using our services. Another thing to point out as well is there's high rates of prefer not to say on these types of questions for certain communities, and this may be due to, again, social factors, or it might also be if we're using the right language and if we're supporting people. And if we look at a national versus East London breakdown, we can see that there's slightly more gay and lesbian people here, slightly more in the other category, and quite a bit more in prefer not to say. So we're a little bit overrepresented, why this stuff is a little bit more important for us to be thinking about. So let's look at gender identity. So how many of you feel like you have trans or non-binary patients attending your practice? So got some not sures. We've got a definite yes in there. Yeah, and the not sures are somewhat to be expected because we're not very good at tracking this in our systems. But if we look at the national data from this self-report stuff from GP patient survey, we can see that in East London, we have roughly about the same amount of percentage of trans people as we would expect nationally. So we would expect the same amount obviously coming into our systems, but also a slightly higher prefer not to say rate again as well. So what do those numbers really mean? So in 2018, the government estimated that about 0.3 to 0.8% of the population are transgender, but this was done on the basis of just trans men and trans women. So if we extend that definition into a broader sense of gender identity, including non-binary and these other types, this rate might go up to a ceiling effect of 4.5% in adults, and in children it was seen to go up to 8.4%. But I should point out this is US data. However, US data does align with ours quite a lot in relation to disclosure. It's just that we don't really record this as well as US populations do. So trans can be a bit of an umbrella term. It can mean trans men and trans women and non-binary people. And this is why these stats sometimes it's good to dig down into exactly what was asked. And when we think about how we ask this stuff, in the UK, our trans status monitoring is pretty poor. We don't really do it very well in our records. I'll come to that in a bit. And this leads to lots of interpersonal errors and missing people in the system. So I'm going to just go over exactly what it means to be trans so that we're all on the same page about that part. So when you're born, you have your sex assigned or registered at birth. So this is that declaration that's made by the clinicians about whether you're male or female at birth. And then as you grow up, you develop your own sense of personhood. And this is where you get your gender and how you identify yourself and identify yourself in the world around you as well. So this is what you'd call your self-ID of gender. And in this, you tend to find that people largely group themselves in male, female, or a non-binary identity. So when we talk about someone being trans, what we're really talking about is an incongruence between these two factors. So I've popped these lines on here so you can see that when an arrow crosses that incongruence line, you'll see that there is the potential for someone to be trans. So for someone who was assigned male at birth but identifies as male in their gender, there's no incongruence. So this is what we refer to cisgender, cis meaning the same. But for a transgender woman, they'd be assigned male at birth and then identify as female. The opposite would be true for a trans man. And a non-binary person may be assigned male or female at birth, but identify as non-binary. But let me explore what non-binary is in greater detail. So when we think about gender, we often think about it as two finite points of male and female, and there's somewhat of a line in the middle. But this gives us the impression that non-binary people have to present in some androgynous way on this line. And that's not always the case. Really, gender is a bit more of a spectrum, and we know this because around the world there are third genders, and these are other forms of gender that are socially reinforced, have their norms and values, and they've existed for a very long time. And because it's global, we know this is a natural feature of human behavior. There were also some people who identify as agender or no gender, and thereby they don't really relate to these sort of social norms that they see around us in gendered way. But this may be an intensity of feeling. They may be sort of somewhat feeling that way or completely. So if we then look at this spectrum that I put together and we take away what we consider the binary, the male and female, and can leave ourselves with the non-binary section, it's actually quite broad. So when a patient is identifying themselves as non-binary or self-describing in some way, we can see that actually there's quite a broad range of experience there. So again, we should be leading with a sort of person-centered approach and allowing them to tell us who they are rather than just making assumptions of how they've ticked a box or identified. So with that in mind, who do we think are reporting the poorest experience of their GP appointments? Is it cisgender people, transgender people, non-binary people? And I just want you to rate those of who's having the poorest time, so the poorest being first. Okay, so we've got 3 people in already, and we're very confidently saying non-binary, trans, and cis. Just check if there's any more before I move on. Yeah, you've cracked it. That's exactly it. So you can see someone's added trans people in there as well as the first rating. So I'm going to go into this data for you so we can really take a look at it. So this is quite a complex bar graph, but the ones I want you to focus on are the blue and peach ones that are next to each other. So this is the trans people who are non-binary or self-describe their gender. And if we look at people who felt their needs were definitely met, then they are the lowest in that section. And if we look at people who feel their needs definitely were not met, then they also get the highest rates in that section. So we can see that trans and non-binary people are definitely not feeling like their GP appointments are hitting the mark. And if we look at the overall rating of GP experiences and their practice, again, those peach and blue bars are pretty low for a very good rating, and they're highest in the very poor, primarily that trans self-described. So this goes back to, again, what I was saying about people who struggle to fill out these forms and boxes. Sometimes those who don't feel represented in our systems or surveys are the ones most affected. So now I'm going to go on to pronouns, which I know a lot of people get concerned about, and hopefully will demystify them a little bit. So first things first, who's afraid of making mistakes with pronouns? Yeah, got lots of yeses. And that's absolutely okay. Mistakes do happen, and we're just going to go through how they happen and how we can recover. So the first thing to point out is that pronouns are nothing new. They're just a common feature of human or English language. And what we do is we're just replacing a noun or a name with one of these pronouns. The important thing, though, when we're thinking about people and these gendered pronouns is making sure that we respect how someone presents themselves, not only in the way we talk to them, but also when they're not present. So when we're talking to our colleagues or making notes. The most commonly encountered types we have are he, him, she, her, and they, them. They, them being a gender-neutral version. This is used already in common language. It's not so much of a new thing as people think it is. I recently noticed on my own phone that an Instagram notification said somebody had updated their story because Instagram didn't know that person's gender. And that's how common it is in our language. And it's just that some people, like myself, prefer to use it as their main pronoun because they feel more comfortable in that gender-neutral space. So I'm going to give you a patient story here. Hopefully you can hear it, and it will really drive home this point about the importance of pronouns.
Where the doctors all refused to acknowledge me as trans and used the wrong pronouns, like deliberately. It made me feel like I couldn't trust doctors. It made me feel like I had to very much bury who I am and just pretend to be normal, I guess. I've had one really good experience with a neurologist that I saw. She noticed that I'd ticked Mr. on the box, but my doctor had put the referral as female. And so she actually spoke to me sort of briefly about that and just asked what pronouns I'd prefer. And when she then had to write a letter again, she checked what I wanted to actually have on it. And that was fantastic.
So you can see there the importance of how pronouns are for people, and also then the importance of seeing it in letters and correspondence. And also the ability to check in. That clinician there checked in multiple times to make sure they were getting it right. So speaking of checking in, it's an important factor of recovery. So what happens if you do make a mistake, which we all do, I even do with my friends sometimes, it's a natural thing. But what you have to do is just recover respectfully. So if you have accidentally misgendered someone and you need to think on your feet about how do I claw this back, how do I resolve this situation, I've developed this very simple system of AACC, and hopefully it will help you get through those things. So the double A's are almost outwards and the double C's are reflective. And if you're in that moment, you work through this system. So you first acknowledge that you made a mistake. So this is your opportunity to give an apology, but don't oversell the apology. That makes people feel quite uncomfortable. But just acknowledge the mistake happened and then take that opportunity to ask. So clarify. Just like in that past example that clinician did, they just asked and checked. And then that means you can be sure you're going to get it right. And then the work starts for you. This is where you get on the reflexive C's and you can correct yourself. So you can demonstrate your changed behavior and use the right pronouns. And lastly, you need to commit. So you need to make sure that you are upholding this and you are making an effort to make sure you're getting it right every time, rather than relying on that patient to keep reminding you. So I developed that system, must be 2 years ago now. And then I came across this clip a couple of months ago where somebody's using that system naturally, just in a conversation. And it just shows you how easily it can flow through. So let's play this video.
I have two choices here. I can either decide that I'm going to reflect on whatever whatever they just told me, whatever Patrice told me, or
a few moments later.
I said during our exchange we were doing, I think I called you she, and I want to acknowledge that and apologize for that. I'm pretty sure I did that, and it's disrespectful. So I wanted to acknowledge that.
I appreciate that. And honestly, if someone is misgendered, what we actually just appreciate is when folks correct themselves, and you did. You said it, and then you corrected yourself as you began talking. So I knew that was just a slip of the tongue, and that was not it wasn't a jab at me.
So you can see there that it runs pretty smoothly, and it's quite a natural way to recover. So the other thing that's important about pronouns then is why they're popping up in people's emails all the time. So the reason this is happening is because it's a good way for you to demonstrate in a very small fashion that you are aware of the importance of pronouns and you are supportive of the community and inclusion. And you might be able to do this through introductions, just by saying yourself, hey, I'm so-and-so. Sometimes, I do it where my name is Julia Callahan, I use they, them pronouns. And this especially can be a really good way to open that up. But if you are not confident with doing that, or you want to back this up with other methods, you can also put it in your email signature. You can put it in your virtual calls. You can put it on your social media, or even on a name badge. And then that way, it's a really nice thing just to have there, so people, when they see it, they understand that they're going to be respected. So now I want to touch on the patient experience. Now we've sort of covered the basics. Let's get into the patient experience side of things. So I'm just going to run through some stats here. So when we look at the LGBT healthcare experience overall, there's unfortunately a bit of a dark picture. So we know that 23% of our community have seen discriminatory remarks uttered by healthcare providers in front of them. We know that about 14% of our community just avoid healthcare altogether. We know that 57% of trans people avoid healthcare even when they're feeling unwell. I've known this personally from friends of mine who've refused to go to A&E even when they're really unwell for fear of transphobia. We know that from the trans people that do attend healthcare, 38% have a bad time. We know that 19% of our community are not out to any healthcare providers, and this may go up to 31% if they're trans. We know that as well that trans people feel that healthcare providers lack a general understanding of their health needs, and this is at a rate of 45% for trans people and 55% for non-binary people. So there's obviously not a great picture there, but I also want to back this up with some data from the National Cancer Patient Experience Survey. Most useful data we have for our community is from the 2019 data set, which looked at LGB. It didn't look at trans status, that's coming in the new data set. But in that 29 data, we could see that LGBT responders were less likely to be asked their preferred name, less likely to be treated with respect, and they gave an overall poorer rating of care. So there's clearly an issue here. But why? Because nobody's going out of their way to make their patients' lives difficult. So what's happening? Well, we're all affected by implicit biases, and these are the stereotypes and attitudes that we encode from the world around us, from the things we read, from our previous experiences, and these can end up affecting the way we interact with people or the choices we make. And two really key ones that exist in society at large are a heteronormative bias, so assuming that everyone we meet is heterosexual, or a cisnormative bias, so assuming that everyone we meet is cisgender. And when we interact with people in this way, or we build our systems in this way, it can start to exclude people. So this is all about creating the right culture. So it's about thinking, how do we challenge these biases? And it's understanding that we're not trying to reach this idea of competency, because you're never really finished learning these things. It's more about humility and understanding that there's a continued learning process at play. And there's always needs to be room for other people's experiences to be brought into our understanding of how we can support people and systems around us. Because people could be marginalized for many different factors. Obviously, today we're talking about sex characteristics, gender identity, and sexual orientation. But in our Western concept, which is where these examples sit on this diagram, there's many factors that can create barriers for someone. But also, nobody is just one thing at one time. And this is where intersectionality comes in. So this was introduced by Kimberly Crenshaw, primarily looking at the experiences of Black women. And it points out that we can be subject to oppression or barriers from a single point of our identity, but we can also be subject to oppression or barriers when 2 points of our identity intersect. And these can create unique forms of oppression. So we know that Black people face racism, and we know that women face misogyny. So when a Black woman faces these two things at the same time, Moya Bailey calls this misogynoir. Now, this is a sort of fancy term that exists around this one, but not all intersecting factors have a fancy label. So they can sometimes be hard to describe or pinpoint, but it doesn't mean we should shy away from them. And again, they can be compound of more than two factors. So that Black woman may be a Black trans woman, and then you might have trans misogynoir and so on. So it's understanding that when we're trying to support someone, sometimes it's a complex picture, and there may be multiple factors that we need to be supporting people through. So thinking about supporting people, let's have a look at the diagnostic pathway. So this is a diagram from the World Cancer Network. I've sort of neatened it up a little bit and color coded it. So you have your patient interval in the yellow stage where the patient's driving the care. You have your primary care interval where the primary care clinician's driving the care, and secondary care, which is much further into the diagnostic pathway. So on your phones or your second screens, I'd like you to pop a pin where you think there's a significant barrier for our community in accessing cancer services or timely diagnosis. Okay, so we've got one on vague symptom, maybe there's two on vague symptom, but definitely two in the primary care position. Let's see if there's any more that want to be dropped on there. Any more for any more? Okay, in the interest of time, I'll move on. But it's a bit of a trick question, because there's many. So this is where I see key areas of barriers, and I'm just going to work through them with you. So if we look at the patient interval first, so that yellow box, we know that there's a lack of LGBT health messaging out there. It's primarily focused on sexual health, and this can lead to these intra-community health myths and assumptions. So we often hear that women who sleep with women, that's what WSW means, believe that they don't need to attend cervical screening. This sometimes is perpetuated inside the community, but also by some clinicians. And we also know there's a lack of anal HPV risk awareness in HIV positive men who sleep with men, and that HIV positive status can be a risk factor for cancer. And we also know there's less screening attendance and knowledge, and also the trans patients can be excluded from call and recall systems that are the standard. When we think about the primary care interval, we know that our community delays to healthcare. We touched on that before, and we know we have poor monitoring of who is LGBT or other, or who has trans status. But also there's this other thing, which is the trans broken arm syndrome. So this is where the community has developed this term, whereby they feel like they could go to their doctor with a broken arm and still have it put on their transition. And that makes them feel very much unheard when they're in their appointments, and they often get turned away. And when we're thinking about cancer diagnoses, we don't really want to be turning people away because that's the potential for disease to spread or grow. So it's such a common thing that there's even a cartoon that a trans artist has made, where you can see that the doctor is assuming that because somebody is sick, it can't possibly be anything serious, it must just be their hormone replacement therapy. And then also, as the points on the interactive map showed, there is issues around the pathways. So if we think about a vague symptom pathway, this is where opportunities for disclosure is super important for trans patients, so they can tell us who they are and what anatomy they have, because this may not always be immediately recognizable from their records, and I'll explain why in a moment. But also, if you're not aware of someone's internal anatomy, you may be sending them for the wrong screening. I've definitely heard of this happening in the past, where somebody was sent for screening in their stomach because they had abdominal pain, but they didn't realize they were a trans man, and it ended up being more of a gynae issue. And then also we have site-specific pathway. So what if we do know where it is and we're more confident, we get to send someone, for example, into sort of a breast clinic pathway. Then we also have the issue of, are these pathways, if they're quite gendered, are they maybe too gendered and they're going to be putting some people off? So if we do have someone who's a trans man with a tumor in their chest, are we pushing them into a pathway that's just inundated with pink and it's going to make them feel like it's very uncomfortable service? This is also true for lesbian women as well. And there's a piece written by Margulies on this where she calls it pink washing and how it can be quite dysphoric. And also in the secondary care interval, there's a couple of different points of difference, especially for trans patients, and how there's sometimes the need to balance trans-related care and cancer care. And my colleague Alison Berner is the person who you can contact if you have any queries about how this works, or you have a patient that needs additional support. So if we look at cervical screening, so women who have sex with women, if we touch on that first. So cervical screening is recommended for anyone with a cervix who's had anything inside their vagina, and we know that our community has lower rates of cervical screening, and up to 37% have been told that they don't need to be screened. So this goes back to what I was saying before. And we also know about 14% have been actively discouraged. So this is usually where they come out. Sometimes this is through questioning about if they're using protection in sex, and they come out as being gay or lesbian, and then they are told that they don't need the screening and that they can end the appointment. But this is based on a falsehood that you don't need to be screened if you don't sleep with men. So we need to really be challenging that. So now I've got a patient video for you talking about the experiences of being a queer woman in these sort of appointments.
After coming out, I had a negative experience actually during my first pap smear. In the middle of it, started asking me questions about my sexuality, and then giving me quite a lecture about morals and about what was right and wrong to do with sex, and about letting down my parents, all in the middle of the procedure, which was a really sort of traumatic experience. I had a good experience with a GP who wasn't fazed in any way, you know, didn't blink, didn't act uncomfortable or awkward as soon as I mentioned my partner. And from the beginning, I felt that she understood that I was in a same-sex relationship, that it wasn't particularly relevant to the issue that I'd come there for, but if it did come up, it was something that could come up very easily and comfortably.
So you see there's the importance of understanding why these things are coming up, being treated with respect when these questions do arise, and not being made to feel uncomfortable, especially during intimate exams. So then if we think about trans men and non-binary people who were assigned female at birth, so that's what AFAB means. And if we think about that graph I showed earlier about trans status, so assigned female at birth, we know they have lower rates of screening in cervical, and this is sometimes due to dysphoria from the procedure. So that's that intense sort of discomfort about how it relates to their body. This can also happen from screening invitations as well, if they're particularly gendered. There can be some technical difficulties with the procedure, especially after long-term testosterone, which can cause some vaginal atrophy. We also know they're not called automatically from call and recall system at the moment, and also the potential for overt stigma and discrimination from their healthcare providers. Things you can do to get around these things, though, is you can offer appointments at the beginning or end of the clinic, so it makes it easier for them to get in and get out and not feel like they're waiting around too much. Discuss the procedure and options available. This can be using a smaller speculum, taking one home to practice, topical estrogen gels. There's multiple different things. We actually have a video on our website under the My Cervix, My Service campaign, where there's a clinician talking about all the steps he takes to make sure it's a positive experience. Other things you can do is check the name the patient wants to use for the appointment. And I would also recommend that sometimes it's useful to inform people about the higher rates of unsuitable samples or errors sometimes sending things to the lab, just so if they're called back in, they understand it's nothing to be worried about, and they can sometimes be prepared if they might need to go through the procedure again. So with trans men and non-binary people who are assigned female at birth, if they are registered as female still, they'll get those invitations from the Call of Medical Register, but if they're not, if they're registered as male, they won't be getting them. So you will need to request for that screening to happen, and you will need to send that sample to the lab, and we recommend that you put on that form that the patient has a cervix so that the sample is less likely to be refused. It's also important to note the results should be given to you in this case as well, so you'll have to give them to the patient. Because they're outside of the standard call and recall process, they won't get their results directly in the post. So make sure that you're building a good rapport and you're getting those results back in a timely manner. If you are using an HMR 101, there is in the clinical data the perfect place to put that patient with a cervix point, and this is something that a GP in the East London area has told me they do, and it tends to work pretty well. So trans women, non-binary people assigned male at birth. So these people may receive these invitations if they're registered as female in their records, but they won't be eligible because they don't have a cervix. So it's important to discuss that with them so that they don't get confused. And when somebody does re-register their gender on the records, they should be contacted for a no cervix confirmation. But if they don't, you can send that you can submit a cease request to via OpenExeter, but try and do so in a timely manner so that people don't get these erroneous invitations from the prior notifications list. It's also important to note that some of these community members may go get their screening at sexual health centres because they feel like it's a more comfortable experience for them. So this may not necessarily show up on your records as a result, but it's good to check in with people just to make sure that they are still attending screening. Some popular services are Clinic Q in the South and 56T in Soho. So if we look at breast now, so we know from women who sex with women, there's poorer experiences of screening from healthcare providers. There's generally a mistrust and a lack of awareness, which affects people's attention to attend mammography. Lesbians are more likely to delay going to their GP with symptoms, bisexual sometimes show an even greater delay. And in line with this, there's less preventive care. So mammograms are usually sought as a confirmation of a symptom rather than routine screening, which is what we would hope people be engaging with. And we also know there's a lack of robust data for Black and minority ethnic sexual minority patients. And this shows, again, this bias that sometimes exists in research, and it makes it harder for us to give a full experience and make sure we're getting the right data for our communities. So for trans men and non-binary people, if they haven't had top surgery, so if they still retain their breast tissue, they should still go in for regular breast screening and still be examining themselves regularly. If they're registered as female, they'll get those invitations. If they decide to register as male, then you'll need to refer them in to the service. But if they have had top surgery, so if they've had that tissue removed, then they will no longer be considered eligible for breast screening, and there is a dramatic reduction in risk for breast cancer, so it should be safe. But we should still be encouraging people to check themselves regularly. And it's important to note that trans men and non-binary people who sign female at birth may want to refer to this tissue as their chest. So if you do feel like you need to talk about breast cancer and breast tissue, it's important to labour the point of it being clinical terms and still understanding what terms you want to use in that appointment so that the person still feels comfortable. In regards to how to look out for these symptoms, we've created some posters of Copperfield. You can access them on our website. They're free to get, and we also have some print stock if you need it. And it is a really nice way to just encourage people to be checking themselves without having to show pictures of chests that may make people feel dysphoric. And these posters were developed with the community. So for trans women and non-binary people assigned male at birth, if they're registered as female, they'll be routinely invited as standard. And it's important to note that long-term hormone therapies, so feminizing therapies, can increase the risk of breast cancer. This obviously is due to the rise in hormones in the body and also the development of breast tissue. This risk is about 4 to 6 times greater than cisgender men, which may sound like a lot, but it's no greater than cisgender women. So there's no sort of real thing to worry about here. Standard screening protocols apply and it should be fine. It's important to note as well that breast cancers can be sensitive to estrogen and testosterone. So if someone is diagnosed with a breast tumor and they are on these kind of therapies, there may be additional conversations needed about how to progress safely. And this is where my colleague Alison comes in. And it also may therefore affect people who have plans for this transition and how they can do so safely. Now, on to prostate. So although there isn't a national program for prostate, it's still important to bring this up because a lot of people don't know that the prostate remains in situ after vaginoplasty. So it's really important to know that the trans women coming in should still be kept in mind for prostate health checks and be empowered to ask for screening if they need it. But there is some positive research that's come out of the Netherlands that shows that trans women who are on androgen deprivation therapies and estrogens do have a decrease in prostate cancer risk. But then again, because they're taking these hormones, it's sometimes harder to get a clear reading from a PSA. So it's really, again, checking with people about symptoms and if you need to do any sort of manual palpation, thinking about how that would work for a trans person and doing it so respectfully. I'd also say as well, it's important that your trans female patients are open and can disclose who they are when it comes to things like disclosure of lower urinary tract symptoms that might get confused if people don't understand that they have a prostate. And then we have other impacting risk factors that we need more research on, such as BRCA and ethnicity, because we know these to be true in men. So if we think about Black men and their higher risk, but we don't have that detail for Black trans women. So I've touched a little bit on patient records, and I just want to sort of go over where these changes happen and why these errors come up related to records. So when someone changes their gender in the record, they can do so at any point. They don't have to have been in the gender pathway. They don't have to be on the waiting list. They can just choose to do so. And previously, there was a legal requirement to get evidence of name change and things like that. That's not the case anymore. You may want to still get that evidence for your own records, but if you're challenged on this and the person doesn't have any legal documents that can change the name, that's not necessary anymore. They can just do so. So when a patient does change their gender, they're given an entirely new record, effectively. So they're given a new NHS number and they're registered as a new patient. So all the previous medical information really needs to be transferred onto that new record. And you should be explaining this to the patient as well, that this is what's happening. It's also recommended as well to set that record up as either male or female and avoid the indeterminate category, so we can still try and get people into the right screening programs. But I'm going to talk through a potential scenario here of when you're trying to move that information onto the new record. So the great situation would be if the patient permits for it to happen and they're absolutely fine with all the information going onto the new record, great, transfer, it's all done. If the patient's not comfortable with it happening because they want to protect their trans status, their history, they want to make sure that people don't necessarily know they're trans by looking at their medical history, you may want to offer to redact names or certain details from it so that you can still keep that information on. But there also might still be some people who want to oppose this slightly because there may be some gynecological history on their record. So if the patient is still persisting that they want everything removed, then it's important to have that discussion about how you can try and capture the key details in a gender neutral way, just so then you can make sure that that medical history is flagged to the next clinician looking at the record. But in some cases, there may be some patients who decide that they want an entirely clean slate, and they are absolutely within their right to do so, but I would recommend that you are explaining to them then the additional burden that they need to carry to make sure that they are volunteering that information to other clinicians at the right time and when it's necessary, just for their own safety. And if that last case does happen, where the entire record is not kept, I would also try and make a log of that discussion and that the consent has been given for that to be the case. So if this has happened as well, if someone has changed the gender inside your system, it's important that we still try and support people in accessing screening, and that we're not putting too much burden on them for remembering when to go to screening, how to access it, etc. So this is your opportunity to maintain a list of eligible patients, flagging when they need their screening due and inviting them in, and also giving them the information they need about eligibility, or pointing them to resources like our website, for example. With this as well, I know it can feel a bit difficult to find those records and flag them or create systems. So Owen Carter has put together a document which Cherie should have sent round. So there is a click-through guide of how to set this up. So a lot of what I've talked today hinges on disclosure. So patients are often forced into disclosure due to these heteronormative assumptions. So this idea of, are you using contraception? And as we saw in that scenario as well, that can be a bit of a difficult conversation and makes people feel like they're being outed through it. So it's really thinking about how do we create a space where people feel comfortable to come out, rather than we're sort of quizzing them and making them come out. And also, if someone has disclosed, just checking with them, are they comfortable with that information being recorded? If so, where can it go? Who can we tell? Because our systems don't accurately record this stuff at the moment, it makes it a little bit more of a nuanced thing to have to manage who can know and where that information is. Also, when we think about this in relation to trans people, especially those with a gender recognition certificate, it's important to know that it is unlawful to reveal someone's gender history, so their previous gender, without their permission. So if someone has come out to you as trans, it's always good to check, can I tell other people about this? Can I put this in your notes? Are you comfortable with this being here? And also, this is a good opportunity to explain why it's important, how it can help the patient's care, and who will see it. But there's also other barriers. So there's barriers for ethnicity and culture, and especially for certain communities, when we think about this, these conversations may be kind of new to them and maybe a little bit uncomfortable. And there may be additional risks associated with them. So this may be homelessness, community ramifications. And this fear can sometimes be more pronounced if the GP is from the same community. I think sometimes we make the assumption that if we match patients and GPs together who sort of seem similar, then there's going to have a good rapport, but this isn't always the case for our community. So this is where good social prescribing to support patients who are in these positions is really important. And that's why you've got that really long document that I've sent around via Charisse. And it's also important to understand that our community, the LGBT community, is a valid culture of its own, and we have some of our own cultural norms around family and support, and making space for that is important. So I've got another little video for you here.
I came out to my parents when I was in my early 20s. My mum came into my room and she questioned me about my sexuality. And when she questioned me, two thoughts came into my mind. One was, I can lie my head off about this and get myself out of this situation. And the other thought was, I've got an opportunity here, to be honest. I said this in Urdu, which is my mother tongue. I said, Ammi main gay hoon, which means Mum, I'm gay. My mum started crying, I started crying. My dad came into the room and he started crying. There was an occasion where my mum asked, whether I needed to go and see a doctor. I said to my mum, this isn't something that, I can take a medicine for.
So the reason I wanted to show that clip is because it shows that disclosure sometimes when we look in media, it seems like a really big celebration, but it can actually be quite nuanced and difficult. The other thing we also need to be thinking about then is, with that difficulty, are there other things where medicine has sometimes been weaponized against young queer people? So the threat of conversion therapies and so on. So you may be coming in with the best intentions, but someone may have some previous experiences whereby it may be triggering for them to be talking about these things in a medical setting. And we know, if we look specifically at queer Muslims, we know that they are less likely to be out to their community. And as a result, if their GP is from that same community, they fear being outed, even with knowledge of NHS data protections. And we know that there is the potential conflict between their identity and their faith and honour. And we know that they may be dealing with previous negative experiences of being LGBTIQ+, and how this can sometimes be used against them. But this all speaks to the the idea that we need professionalism over personal bias. So this is how we need to check in with our conscious and unconscious biases, as I've talked about a lot today, and how we need to provide equitable care to everybody. And we need to be speaking frankly about risks and sex and all of these factors. So one example is demystifying these colonial attitudes that exist in the Black community around anal sex and how this can impact people's attention to request prostate screening. There's a lot of work that goes on in this already with barbershops, and it's really fantastic stuff, but we definitely need to be more comfortable just talking about these factors. And also, I think it's important to think about the identity variation in our clinics and how we can use them positively. So if you are having trouble building a rapport with the patient, seeing if there's anyone else in your practice that has a better chance of doing so that we can support each other. And there's many factors that come along with disclosure. So we have, barriers including these biases and assumptions, the patient's fear of poor care, their fear that the healthcare provider isn't going to be so accepting, and so on, and also location and setting. But conversely, we also have these facilitators. So things like inclusive body language are really great, and also inclusive language on our posters and our information, challenging these assumptions that exist around us. And also, if we can make sure that we're perceived to be accepting, that will get people to come in and feel more comfortable being themselves. And obviously as well, if a member of staff themselves is LGBT, that's a really good way to bring it in, but we shouldn't just rely on those colleagues to be driving the change. So some accepting cues that exist and then definitely have been used already are things like the rainbow and like the rainbow badge. And we know it's related to positive feelings about ourselves, so that's really great. And we know that these displays promote inclusion and disclosure. And we know as a community, we are coded to notice these things. But anytime you're displaying these things, make sure you are backing up with training, just so then you're ready for those conversations that might come as a result. And posters are a really great quick win. As always, we have a couple and we're always developing more. We have a new campaign, Best of My Chest, coming out with Nelka soon, which is a really good poster campaign. But thinking about it, make sure that you're moving away from these old biases of sexual health and AIDS and thinking about other ways to be inclusive in LGBT health messaging. And also sometimes thinking outside the box. So a visible equality policy can be just as useful, and it can be inclusive to everyone so that everybody feels like they can be respected in that space. So in this last 10 minutes, I just want to go over some reflections and give you an opportunity to post some questions. So after today's content, I just want you to go back to those phones, and if you need to log in again, the code's at the top, and just rate how you feel in your awareness, knowledge and confidence of this issue and topic now. Good, we see some increase. I'll just see if there's any more scores that want to come in. I think we had 6 at the highest point before, as in 6 people. Okay, no more coming in, but that's good. Definitely the awareness increasing. Confidence as well being around the middle is sometimes expected because it is a complex issue. I think sometimes it shows when we do these talks that there's still a lot to learn. And this is really just the overview and springboard for you to get more stuck in, especially with the resource we've provided, so you can continue your learning. So thinking about today and thinking about actions you can take from it, how likely are you to apply some of today's learning? So thinking about your inclusion, your posters, your policies, etc. How likely are you to try to implement some positive change? Very likely, that's great to see. And remember, those changes can be quite small. It can be things like, again, having that policy on display. It can be making sure you make sure everyone knows where that social prescribing document is so that you can help patients. There's lots of things that can be done that don't take too much change. Great, that's good to see good scores in that category. So thinking about that then, putting you on the spot, I just wanted to see what actions you might take. So these don't have to be sort of concrete plans, but what things off the top of your head do you think you can address that will improve patient experience and timely diagnosis? Again, this is all anonymous, so just feel free to throw some thoughts up there. Don't be shy. You can just pop some things on there. Doesn't have to be too much writing either. Just some small thoughts. Yeah, introducing with your own pronouns. That's a really good one. Adding them to emails is also really good. Looking at further training, that's a fantastic one. Definitely look. Pride and Practice do some more GP specific training. You can usually get it funded either through local commissioners, sometimes even the council. So that's a good one to be looking at. Changes to registration. Yep, the primary care service actually has some really good documents on how to do this. And I think I've handed that out in the pack as well, that it kind of shows how that works. And use the resources given. Love to see that, because I did put some effort in putting them together. So then lastly, there is the evaluation. So we'll be sending around the evaluation link for you, but there's a QR code if you want to get straight to it from today. And also there's an opportunity for questions. So you can either tap them into the app and they'll come up and I can answer them, or if you just want to unmute because it's a small group, we can just chat about them as well. Any questions yet? There can also just be clarifications if you just want me to go back over something. I'm just going to pop the evaluation link in the chat in case anybody doesn't want to use the QR code, and I'll make sure that Cherise sends it around afterwards as well. So I will close the slides and check, Cherise, if there's anything in the chat. I don't think so. Okay, well, if there are no questions, I hope that's because everything was explained really well. Oh, one's come up. Okay. Is it okay to say at the start of the conversation with a trans non-binary person that I'm a little new to this, I do not intend to upset you? Absolutely, absolutely. I think it's about as well, if you put it in the position of new but doing your best and making sure that it doesn't sound like new, so excusing your mistakes. Because that sometimes definitely happens where people do this thing of, okay, well, I don't really understand this, and that can sometimes go a little bit badly. But if you go with the angle of, as you've touched on here, I don't want to upset you, just go in the sense of, just want to be respectful. And I think being respectful as well is a good way to do it, because if you use words like upset you, etc., it brings it into quite an emotional space already. So if you go into this idea of just want to respect you, just want to make sure I'm getting this right, just want to make sure I'm doing the best here as I can, it keeps it in this positive forward momentum. And that can be really useful to make sure you're setting a good tone. Okay, any more questions now the ball's rolling? Nope, I don't think so. So obviously, if anything comes up, you can get in touch with the charity directly. You'll have all the information from the handouts. If you need any additional support, signposting or support, that's what we're here for. We also do peer support for patients over 18. And we also do additional learning. We'll have that Best for My Chest campaign coming out soon, so watch out for that. We'll try and make sure posters get around to people. And otherwise, thank you for your time and attention.